Hey everybody, this is Anja Sunadli from Kuna Fire Department, and November's Target Solutions training is going to be focused on pediatric airway. So our block training in October focused on general airway, so now we're going to kind of get more specific and talk about the pediatric airway. So pediatric airway emergencies are a pretty small portion of what we actually respond to, but when we do respond to them, they're pretty scary, right? We don't go to them a lot. They're not super familiar for most of us. So they're, as such, considered high risk, low frequency events. And so these are ones that we really want to make sure that we're training on regularly so that in training and practice, we feel really comfortable so that when the actual emergency happens, we don't feel so completely overwhelmed. So a few basic goals for this training. We're going to review anatomy of the pediatric airway, and then we're going to go over BLS and ALS management of the airway. So this presentation and training is not focused as much on respiratory emergencies and like the physiology of those emergencies, such as croup and epiglottitis and other aspects of that. We're focused more on the physical management of what happens if we need to control a pediatric airway. So talking about anatomy. Now, we've all heard this 1,000 times that kids aren't just small adults. But what are the actual differences and why do those differences matter? So kids have much bigger heads and shorter necks in proportion to their body size than adults. This is kind of just a basic overview, but in kids, the head can make up to 25% of the kid's size as opposed to like 6 to 9% for adults, and much shorter necks. As a result, this makes them more prone to obviously falling and hitting their heads and trauma, as we're all aware, but it also makes it much harder to create a nice open airway space for either BVM or BLS management or ALS management. The tongue. The tongue takes up a much larger amount of space in the mouth in kids than in adults. What this means is it can block the airway a little bit more easily. It's a little bit harder to manipulate out of the way. And this also explains why infants are obligate nose breathers. This is why they're able to feed and breathe through their nose at the same time. So this picture here, this is obviously an exaggeration. This is a kid with macroglossia, which is an actual medical condition. But it's a good kind of demonstration that kids' tongues tend to take up much more space in the oropharynx. So kids have shorter necks than adults. We already went over that. But in addition, the actual anatomy of the trachea is quite different. So as you can see here, it's much more conical shaped than the adult. It narrows at the level of kind of the subglottic area, whereas adults, the narrowest area is kind of more at the vocal cords. In addition, all of these cartilages are floppier and less defined, which can cause this trachea to bend and essentially become occluded more easily, versus the adult where this cartilage is a lot more rigid and holds it open. So all of these things make the actual process of intubation more difficult. It also makes it more difficult to keep this space open and from occluding itself. Speaking of the epiglottis, there are actual significant differences in the epiglottis of an infant or a pediatric patient versus an adult. So an infant epiglottis is a lot floppier. It's also either going to have a more U shape or what they call an omega shape. So as you can see here, this kind of omega shape here versus the adult, which is much more kind of just gently rounded. And the difficulty with this is that it's a lot more difficult to lift out of the way. Now, that is why we actually use or prefer to use Miller blades versus Mac blades in infants or kids. And if you're using a Mac blade, a Miller blade, you're actually going to put the tip of the blade underneath the epiglottis and lift the whole thing up, as opposed to in the vallecula space, as you would an adult and with the Mac. So the Mac is designed to kind of go into that vallecula space and lift up, as opposed to a Miller, which is actually designed to lift all of this out of the way. So this slide shows just an overview of all of the differences that we've already discussed, as well as kind of names a couple others. So as we already showed, the tongue takes up a lot more space in the oral pharynx. The epiglottis is floppier and more U-shaped in the child. The vocal cords, in addition, also have a slightly different angle to them in adults versus children. And more importantly, the larynx of a child is located more anterior and more superior. So what that means is more forward and more up in a child than in an adult. So essentially what that means is all of this anatomy is just kind of compressed in a smaller space. So it just makes it a little bit harder to manipulate as opposed to kind of having a little bit more space to work with in an adult. And of course, finally, the lungs, obviously less capacity in a child. Average tidal volume or lung capacity for our purposes is going to be 6 to 8 milliliters per kilogram. And why that is important is when you're talking about bagging a child, you want it bagged just until chest rise using a very small amount of pressure because they're much more susceptible to barotrauma than adults are. So, again, why is all of this important? Basically, the pediatric airway is a lot more prone to obstruction than the adult airway, not just from foreign body obstruction, but just obstructing itself. So positioning is super, super important because without proper positioning, the tongue can fall back and obstruct the airway. The trachea can become occluded just because it's hyperextended or hyperflexed. So that moves us right on into positioning. So the next couple slides are taken from the Tufts Medical Center, Department of Anesthesiology in Boston, Massachusetts. And we chose these slides because they really provide an awesome step-by-step system of how to properly align a pediatric airway. And they provide some great visual examples of how to do that. The key with this is that there's a couple steps to each one, but essentially each kid is going to be different, right? Whether it's an infant or a toddler or an 8-year-old, they're all going to have slightly different ways to put the airway into the best position. But it is worth taking the time to position the airway properly for airway management because it's going to make your job way easier down the line. So the 3 main criteria that Tufts use to align the pediatric airway are as follows. So you want to have a aligned chin glabella plane. So what that means, the glabella is the smooth part of the forehead in between the eyebrows. And of course the chin is the chin. And you want that to be, if you imagine drawing a line between your eyebrows and your chin, you want that to be nice and horizontal when you're looking at the kid from a side view. You also want to keep that anterior or front neck space nice and open. And you want to align the external auditory meatus or ear canal, which is a lot easier, horizontally with the suprasternal notch. The suprasternal notch is that depression at the very top of your sternum in between your clavicles. So to achieve kind of those 3 previous steps that we talked about, there's 3 steps to actually meet those criteria. So after you do each step, you want to reassess and see where the airway is and see if the next step is actually necessary. So you don't necessarily have to do all 3 of these. You want to start with the first one, move to the second one, et cetera, to get that airway into line. So they're pretty straightforward. The first one is just a simple head extension or head tilt chin lift, as we would call it. Oftentimes, especially with older kids, this will bring the airway into perfect alignment. With infants or toddlers, you may need to place a shoulder roll and you may need to add a headrest. So next couple slides, we're going to see some pictures that will hopefully make all of this a lot more clear. All right, so this is an example of the first step, which is a simple head extension. So all we're doing is doing a nice head tilt chin lift. The technique that they're using here is just to use the hand at the top of the head and press kind of slightly down in this direction. And as you can see, you've got, here's your nose chin plane, right? Or the glabella chin plane, as they would call it. And this is pretty horizontally aligned right now. This anterior neck space is nice and wide open. And the ear canal and the suprasternal notch are pretty much horizontally aligned. So just this simple movement brought this kid's airway into perfect alignment. So this is an example of one where it may not work. right? So again, we're using a simple head extension or head tilt chin lift. And as you can see, the chin is above the glabella, so it's tilted back. We don't like that. The anterior neck space is not quite as open, and there's definitely a nice tilt here to the ear canal and the suprasternal notch. So this is an example of when a simple head extension is not going to work, and you're going to have to go on to the next steps and add a couple things. So first step is adding a shoulder roll. So as we can see, when we've added a shoulder roll, we've now opened up this anterior neck space. However, we've increased the angle here for the glabella chin plane and the ear canal with the suprasternal notch. So these are overly tilted. And while it seems like maybe tilting it this way is going to help open up the airway, as we remember from our pediatric anatomy, because of how floppy the trachea is, this hyperextension can actually occlude the airway. So we don't want to do this. So after we add the shoulder roll, we're going to go on to our next step, which is adding a headrest. And so we've got this nice lift underneath the shoulders, and we've added a headrest. And what this does is now we have this nice open anterior neck space. The glabella chin is nicely aligned, and the ear canal and suprasternal notch are nicely aligned. So this is an example of a perfectly aligned airway. This is going to be super easy to bag, BBM, manage, intubate, whatever steps you need to take to manage it further. And so we're commonly familiar with this term as the sniffing position. So what we did in those previous slides is essentially put the infant into a sniffing position. So that's our goal with these 3 steps, is to get into this nice sniffing position where the head is slightly forward. Again, our 3 kind of criteria here: the glabella chin plane, neck is nice, wide and open, ear canal and suprasternal notch plane is nice and horizontal. And this is pretty simply achieved with a shoulder roll and a headrest. So this is the position that you are looking for when you're aligning a pediatric airway. And this is honestly the position you're looking for when you're aligning an adult airway too. It's just much easier to achieve in an adult airway with sometimes just a simple lift under the head or a head tilt chin lift. Pediatrics, you're obviously going to use more towels. So those last couple pictures were obviously of infants, but the same criteria and methods can also be used on older toddlers and children. As we get up into older children and adults, again, like I said, it's going to be a little bit easier to bring these airways into alignment with less props, if you will, but the theory and the techniques behind it are still very similar. So here's a slightly older toddler, and all they did with this toddler was place a pillow underneath their head, and it looks like they may even have brought the head of the gurney or bed up slightly. And this worked out really well, right? So you've got a nice nose chin plane that's nice horizontally aligned. Your anterior neck space is nice wide open. And the ear canal to sternal notch plane, again, is nice and horizontal. So something using as simply as a pillow and just a bit of a lift at the head of the gurney could easily bring a kid into line. So this is an example of a, looks like, 8 to 10-year-old kid lying flat on a bed. So as we can see here, this is not really what we want to see because the forehead and the glabella and the chin are not horizontally aligned and they're pretty tilted. You do have a nice anterior neck space. It does look like there's a bit of an angle too here between the ear canal and the suprasternal notch. So what would we want to do here? I'm thinking probably some sort of a headrest underneath this kid is going to bring him into a nice alignment. Oh, he's 6. Okay, not 8 to 10. And look at that. You bring, looks like a folded blanket underneath the head, and everything goes into alignment. So these are really, really simple, easy maneuvers that don't take a ton of effort. They're using materials that we have readily available, whether it's blankets or pillows or towels that we have in the ambulance, to just really simply bring this stuff into alignment. All right, so we've talked about anatomy, we've talked about proper positioning, and so what's next? BLS airway management is what's next. As we always say, BLS before ALS. So proper BLS management is going to reduce the likelihood of ALS complications. If we can effectively manage a pediatric airway using BLS maneuvers between positioning, simple airway adjuncts such as NPAs and OPAs, and if the child is bagging well and their oxygen saturation is good, then we shouldn't really have to move on to further ALS management such as intubation or, heaven forbid, a cricothyrotomy or a needle cric. So before we even get to the point where we have to bag a kid, conscious kids are often going to put themselves into an ideal sniffing position, right? So this is what we call the tripod position, but if you were to look at it from the side, you can see that the kid's head is slightly forward. You know, the chin and forehead are nicely aligned. I'm not sure how this would look, but they've got their airway nice and open, and you're going to hear them sometimes with this grunting sound, which is to keep those alveoli open. But if they're kind of in this position, they're definitely experiencing significant respiratory distress, but they're positioning themselves appropriately. So when a kid has already positioned themselves this way, we don't want to disturb them too much. So it's best to allow them to remain in this position as much as possible and just support them with supplemental oxygen or whatever your medication is for whatever's going on, whether it's nebulized albuterol treatment or possibly nebulized epinephrine for epiglottitis, or sometimes just humidified oxygen. And we humidify oxygen by just using a nebulizer and some normal saline. And that is going to help keep this kid nice and happy. Now, if that kid in the previous picture starts acting really tired, if they're no longer alert, if they're no longer to hold themselves into that position, that's when we want to get into the more advanced BLS, the more ALS BLS, essentially. And what this is going to look like is more likely some positive pressure ventilation, which using a bag valve mask. So in our system, we have the new BVMs, which are the small adult BVMs, which we can use on both pediatrics and adults. They come with multiple size masks, so you want to make sure that you're choosing the right mask. And an appropriately sized mask should fit over the nose and the mouth without extending over the chin and without extending too far out over the sides. So you should be able to get a nice seal with it. And then you're going to want to choose appropriately sized airway adjuncts. So OPAs or NPAs if the child's big enough to accept an NPA. Something to note with NPAs in kids and toddlers, they're much more prone to nosebleeds than adults are. So you're definitely going to want to use some of that phenylephrine spray if you can, and make sure that it's lubed appropriately and make sure you're inserting it nice and gently. You also want to make sure that you are using the right size BVM. As I said, we've got the small adult BVMs, which are appropriate for older children and adults. If you're working on a toddler or an infant, of course, grab that infant BVM. Remembering that the average tidal volume for adults and kids is going to be about 6 to 8 milliliters per kilogram of body weight. And really, for practical purposes, we just want to bag just until chest rise, right? You just want to see that chest just barely rise, and that's how you know that you've gotten the appropriate tidal volume. You also are going to want to keep an eye on your manometer on those BVMs and keep that in the green and adjust your PEEP appropriately. So we mostly want to avoid hyperventilation and hyperinflation. So if you see somebody that's getting real excited and bagging really hard, you know, make sure to coach them, right? We're all in this together, so we really want to make sure that we're all keeping an eye on each other because it's really easy to get excited and start bagging a kid extra hard and extra fast because it's pediatric and everyone's adrenaline is rushing. So remember to kind of take a minute, breathe yourself, and slow down that bagging. As you can see here, we're demonstrating a nice CE technique, but with infants and pediatrics, it is also a good idea to use a two-handed mask seal if you can. So if you're able to, if you have the team members and the staff available to do that TE technique that we reviewed, it works really great on kids as well, especially with pulling the jaw and chin up into the mask as opposed to pushing this down. All right, so moving on to ALS management. Okay, moving on to ALS airway management. So this next section is actually going to be pretty short. The reason being, if you're like me, talking about ALS airway management is not nearly as effective as watching it. I'm much more of a visual learner. So what we talk about when we talk about ALS airway management, we're usually talking about intubation, right? And intubation is something that's much easier to demonstrate in person with visuals, with hands-on training than it is to just talk about it in slides. So all of the BLS management, the positioning, and the anatomy that we've talked about, all that is going to contribute to good ALS airway management. That's also why we've included a lot of videos with this training further on in your Target Solutions training. And those are really going to be kind of the focus for the ALS airway management. So we're just going to discuss a couple points to think about when you think about ALS management, and then go ahead and watch those videos, and you'll be able to get more of a visual idea of what we talk about. So if a pediatric patient is being bagged and we've got the airway in the proper position and their anatomy is nicely aligned and everything that we're doing just isn't working, they're still going downhill, we're still not getting good oxygen saturation, that's when we want to start thinking about intubation. And when we talk about intubation, this is really going to be an all hands on deck situation, especially on a pediatric. Everyone's adrenaline is going to be going through the roof. So we want everyone to really focus on using the resources that we have available, right? We have a lot of resources to help make the pediatric intubation maybe not easier, but maybe a little bit less overwhelming. So of course we have the access length-based tape. We have our color-coded pediatric kits. We've got our SWOs. And we've got other paramedics on scene, hopefully, right? And you've got your supervisors. So using all of these references, all of these resources is going to help out. So making sure that you're pulling out your tape, making sure that you're getting the appropriate color kit, making sure that you're double checking your SWOs and bouncing things off of a fellow paramedic or a supervisor there. So when you decide to do something, confirming it with them before we do anything. So choosing a blade size, this is just a basic overview of what blades you might want to use. These are also going to be referenced in your SWOs and your length-based tape. But generally speaking, for very preterm infants or preterm infants, you're going to want to use the smallest Miller blade possible, which is a 0.0. For a preterm or just a brand new baby that needs to be intubated, an 0 should be, or a 0 should be efficient. Infants, essentially a month old to 2 years of age, you're going to be in the 1 range, and 2 to 8 years of age is going to be a 2. Generally speaking, we're going to use the Miller most of the time. As they get older, it may be more appropriate to use a MAC. This is directly from Appendix 2 in your SWOs dealing with the intubation procedure. How to estimate your endotracheal tube size, age plus 3 divided by 4 should give you the appropriately sized tube. There's also this handy chart here, just looking at weight and size of tube. This will also be referenced in your access length-based tape, as well as in your pediatric color-coded kits. Most of these kits should carry at least 2 tube sizes for you to choose from. And whenever you're intubating, it's always a good idea, once you've chosen your size of tube, to have at least one of the size below and size above in case things change once you get a visualization of that airway. So, intubation of a pediatric patient, and any patient for that matter, is a all hands on deck activity. So now is a good time to pause this video and go ahead with your crew, grab your pediatric bag, get it out, open it up, review all the equipment that's in it, make sure that all of your team members know the equipment, know the names of the equipment, know where to find it, so that when you're about to intubate a kid and you're like, where's my bougie, someone knows where it is and where to grab it, right? Everyone needs to be familiar with this procedure. Even though it's an ALS procedure and we think of that as a paramedic level skill, and it is, everyone needs to be involved and everyone needs to know the procedure from start to finish. So the next part of this training, again, we're not going to go over the procedure of pediatric intubation. It doesn't differ too much from adult intubation, other than you're going to have those differences in anatomy and sometimes difficulty with visualizing the airway. And that's why we've included a lot of videos after this presentation for you guys to watch. So hopefully that will demonstrate kind of that airway positioning technique a lot better, as well as watching different BLS techniques, talking about anatomy a little bit more, and just kind of reaffirming everything we've discussed so far. So it's important to note these videos that follow are for educational purposes only. Access protocols always supersede any protocol you might see used in these videos. And some of these videos are older and show providers without using proper PPE like gloves. So remember, we're always going to use our proper PPE. Again, they're for demonstration purposes only, but hopefully by visually seeing a bunch of kids with airway management, that will kind of help get your head into that space for pediatric airway management. Thanks for listening. Here's a couple resources if you guys want to look at where we've gotten this information from. I highly recommend the Tufts Medical Center slides that we demonstrated here. Go ahead now, move on to the next videos, look at your equipment, and if you've got pediatric intubation mannequins or can grab those, go ahead and practice a couple times on that as well. So thanks again, and go on and manage that pediatric airway.